Dive right into our program. Today, our facilitator for this week's virtual book club for dementia caregivers is the author of Cruising Through Caregiving, Reducing the Stress of Caring for Your Loved One, and a gerontology instructor at Johns Hopkins University's Certificate on Aging program. She has been featured in national media, including the Wall Street Journal, the Huffington Post, the Washington Post, and the Chicago Tribune. When she's not speaking and writing about caregiving and healthcare, she can be found watching reruns of The Office. Please welcome Jennifer L. FitzPatrick, MSW, LCSWC, CSP.
Welcome to the Virtual Book Club for Dementia Caregivers, Session 14, and this is a tough topic. This chapter of Cruising Through Caregiving about death and dying is a challenging one, and that's why I'm so glad that we have a really fabulous expert on today to talk about it and to help us navigate this challenging area. And of course, Cruising Through Caregiving is for any caregiver, for somebody who has any condition, but of course the Virtual Book Club is specifically for persons that are dealing with dementia caregiving. So this program today will be tailored toward specifically dementia caregiving and death, dying, and grief. Before we get started with our content, as always, I want to be giving a big, warm welcome to Hilarity for Charity, hilarityforcharity.org, and Oasis Senior Advisors, oasissenior.com. And both of these wonderful organizations have been sponsoring the Virtual Book Club for Dementia Caregivers. And don't forget that you can always check out the book club at the Hilarity for Charity YouTube page. That is where it's being housed, and also on the Cruising Through Caregiving.com page, where you can check out old episodes if you want to revisit content, listen to one of our wonderful experts again. So welcome, and thank you again to our sponsors. Now I'm going to welcome our guest, who I'm so excited to have on today. I was so grateful we were able to get her. So welcome to Dr. Jennifer Kennedy. And Jennifer is the Senior Director of Regulatory and Quality for the National Hospice and Palliative Care Organization. And she's been with them since 2006. She's got more than 30 years of experience in leadership, nursing, and working in diverse healthcare settings, and worked with hospice and palliative care for nearly 20 years. Bachelor's is in nursing, and she has a dual master's degree in health education as well as case management, and her doctoral degree is in health education and policy. So she's very well suited to being the regulatory and quality specialist at National Hospice and Palliative Care Organization. She serves as faculty at national and state conferences and develops materials for hospice and palliative care providers. And she's also serves on the Joint Commission's Home Care Accreditation Advisory Council. Also has been on the American Nursing Association's National Palliative Nursing Task Group. So we are in great hands today, and we are really, really lucky that she was able to fit us into her schedule. Welcome to Dr. Jennifer Kennedy.
Gosh, that's quite an introduction. Thanks so much, Jennifer. I'm so pleased to be able to be with you today.
Yeah, it's great to have you here, and we're going to get into some real serious conversation, but we're going to try to keep it as practical as possible for all of those who might not be comfortable with the idea of death, dying, and grief. I think a lot of times in our culture and in the United States, a lot of people are really uncomfortable with the topic of death. Jennifer, do you find that as well?
Absolutely. You know, as we've seen our healthcare continuum evolve, it's really, we're really seeing that healthcare is geared towards curing everything. What can we do to cure? And, you know, when we, look at the bigger picture, the circle of life still is we're born, we live our life, we may have some health issues along the way, but no one has come up with the immortality pill. So death is a natural part of the process. And I think that as technology has brought us forward in terms of getting health issues towards a cure, if you will, there is medical futility that happens. In that, what I mean by that is that physicians are not ready to give up on their patients, and they may recommend, well, let's try one more round of chemo, or let's try one more round of radiation. So there is that aspect of the healthcare system that I think projects to patients and families that, oh, you know, we're gonna be able to beat this thing. We're gonna be able to, you know, lick this thing, and not until it seems to what I'm seeing in terms of trending as patients are referred to hospice is that we're seeing an upward tick of patients being referred really late in their disease trajectory, and they're only spending maybe a week, or if we're lucky, 2, with hospice care. And that's really not enough time for hospice to do all the good work that we can do with patients and families.
So we're going to actually, I'm going to stop you there because we're going to ask a little bit more detail, because I bet that there's folks listening that really have no idea what hospice is, or they have a lot of misunderstandings about hospice. So I'm going to ask you to hold that thought for a couple of moments. But I think you're really on to something about docs and nurse practitioners, physicians' assistants. They really want to cure, they really want to make folks better. And in particular, when there's an Alzheimer's diagnosis, or Lewy body dementia, or frontotemporal dementia, they find those diagnoses so frustrating, so tough, because right now we don't have a cure.
We don't, and that's the sad thing about this particular disease, is that while we're working on trying to figure it out, and it does take time, there is no cure today. So we've got pharmaceutical interventions that can help, depending on when Alzheimer's is diagnosed, that can help slow the process, or boost the patient's potential and quality of life for a limited amount of time. But at some point, those medications are not going to work anymore. So I think, and they should be, doctors should be positive. They should do all the things that they're supposed to do in terms of offering positive interventions, but I also think that the healthcare system can do a better job in offering options. Yes, we can give you these pills for now, but here, you know, there is no cure, and here are the options down the line that you may be able to consider. That isn't happening with the whole conversation of when a patient is diagnosed or early in their diagnosis of Alzheimer's.
Absolutely. You're absolutely right. So what I want to share again, and I have to bring this up, is there's dementia like Alzheimer's, Lewy body, frontotemporal, vascular dementia, and all the other dementias are currently terminal illnesses. And I got to tell you, Jennifer, I know that I'm sure you know this. It really is baffling, because so many times I see family members that are really surprised about that. That I think sometimes docs make the assumption that maybe the family understands that they realize it, but a lot of people just don't realize that their loved one is facing a terminal condition.
Oh, I would totally agree with you, Jennifer. I think that definitely there's room for performance improvement in terms of physicians really laying out the picture of what this disease is and what the patient and the family can expect as the disease progresses. And I think you're right that there are shortcomings in that area.
Yeah, and I think that, I mean, I've talked to so many families over the years, and maybe there's some of us that are joining us today that are in this position that are just are very startled when they realize that their loved one is, maybe they accept, okay, mom's not going to remember her birthday, or she's not going to remember that I'm her daughter, but she's not going to die from it. But these are currently, and I say currently because I'm an optimist, and I hope that at some point we do have a cure. Hilarity for Charity always says, until there's a cure, there's care, with their respite grants. But right now they really are terminal illnesses. And so people need to recognize that and realize that. I think when someone, a doc or a nurse practitioner or somebody tells you that your loved one has a cancer, that everybody knows that there's even if it's caught early, everyone knows that it's a possibility that someone could pass away from that. But when there's a dementia diagnosis, I think a lot of people just don't realize it.
Absolutely, they don't. When you look at Medicare statistics, when we look at them specifically for hospice, Alzheimer's death has been the #1 in terms of the top 5 diagnoses for the last several years. So we know that it definitely is a terminal illness. The information, the statistics and data is publicly available, but I don't know what the barrier is in terms of physicians being more transparent about what to expect as that disease progresses. And again, physicians, their job is keeping the patient healthy, or fixing a broken leg, or doing a surgery to make improvements. They're all in terms of promoting longevity, right, and preserving mortality. So again, I think there is a mindset within healthcare providers in general that they're failing patients and families when they have to give them the bad news. And quite frankly, Jennifer, a lot of docs are not comfortable in having those conversations with patients and families. They're just not comfortable. They don't know how to do it. They don't know how to break bad news.
I just also want to say that we're not picking on docs right now. What we're saying is sometimes maybe the doctor doesn't know how to exactly talk about it, but also I think that sometimes the doctor's so caught up in helping the family figure out meds and figure out, okay, well, does this person need nursing home care or assisted living, or, is this caregiver burning out? I don't think that they do it intentionally. I don't think most docs are trying to do the very best that they can. I think it's simply that we're limited with our time with docs, which is why we did a week of this
right,
based on just all the other resources that can help you. So yeah, I just want to make that really clear that we're not trying to blame docs. Docs have a tough job, but the family does need to prepare. And so there's a couple things I wanted to share before we get into a lot more detail, because I have a lot of questions for Jennifer. So in terms of if you are in the case right now, if you're a caregiver on this program and you've got a loved one who's just been diagnosed, or they're in the early stages, you've got a window where you can do some prep. You can ask that person to update their advance directives, let you know their wishes, talk about what their end-of-life wishes are. What would they want? What would they not want? Who would be their healthcare and financial power of attorney? Because maybe there's folks on this program today that are saying to themselves, gosh, I wish my loved one did tell me, because he or she is in the mid or late stages and we don't have that information. In the early stages, the goal, we hope, if that person can update will and trust if that's their desire. And not addressing this impacts everybody, not just the patient. It impacts everyone in the caregiving crew, all the family members, anybody, because they're left guessing. What would this person want? So Jennifer, I'm wondering, do you see this where families are guessing? What does my mom want? Because the person's no longer able to tell them.
Absolutely. I think that not as many people as we think or we would like to see are actually actively doing advanced care planning or completing advanced care directives, or even having those conversations when, if they are the patient with early onset while they still do have mental capacity to say, here's what I want, here's what I don't want. They're not having those conversations. And talking about, moving towards end of life is difficult for anybody. So when we talk about advanced care directives, you should be making those plans with your advanced care directives when you're well and you're not, sick, or you don't have a particularly exacerbation of a health issue. You should be doing that when you have a clear head and you feel very well and you can make these decisions. But we're finding that that's really not happening. And by the time someone is getting towards end of life and their disease process is pretty advanced, either they didn't have the conversation or they didn't have enough contact with their family members to communicate what they want or what they don't want. Or maybe their family member hasn't even, been lived away from them for so long, they don't really know them anymore. Because as we know, as we age, your perspective changes, you know? So I think there's a lot to be said for having those conversations. They may be difficult to have, but if you start having them as, hey, Jennifer, I don't think that I would ever want to be on a ventilator for an extended amount of time. That wouldn't be a good quality of life for me. And I would just tell my family that. And I have told my family that. They understand right from the get-go, what I feel is quality of life for me, and so that they don't have to make that decision of what they think quality of life is for me.
That's wonderful that you're having those conversations. I will disclose that I will turn 46 next week, and I have had my will, trust, and advance directives for over 10 years.
That's good. I'm glad to hear it.
Well, and my husband has too, and he's 47. And I'll tell you, this is kind of maybe not the best reason, but of course, all of what you just said is part of this. I don't ever want to put burden on someone to try to figure out what my wishes would be, but also I wanted to be able to say that publicly. I'm in healthcare. I work in healthcare, and I wanted to be able to say, you know what? Everybody, really anybody and everybody should have these documents together to say, look, here's what I want, here's what I don't want. And especially those of us who, because in most states, your decision maker will be your spouse if you're married, but it can get really sticky if it's a second marriage, so put it in writing and verify, here's who I want making my choices if I'm not able to speak for myself. So that's just a little. So what I would say is, if you're a caregiver for someone who's in the early stages, please try to do this, work with your loved one. But even if it's too late for your loved one to get this stuff in writing, get yours in writing, and let's try to create a paradigm shift where everybody has has done preparation. So, because families get torn apart about this, because maybe you have four siblings in the family, and mom has Alzheimer's, and it comes up, oh, somebody suggests in the hospital, should we give her a feeding tube? And some family members say, oh, yes, let's do that. And other family members say no. And mom hasn't left us any directives.
Yeah, it can get extremely complicated. And you're right. There can be a lot of strife and anger because they don't know what mom wanted, right? And also, we have a responsibility as healthcare providers to say, all right, this is your mom's health status. Let's say that mom has some additional health issues with Alzheimer's disease, and if we do this, it's going to have this consequence, right? So there's just a lot of different variables that are to be considered for caregivers making those decisions, and they can be extremely difficult. I think it would be much easier for someone to say, okay, my mom said I don't want to be on a ventilator for an extended amount of time, rather than a daughter having to make that decision to take your mom off the ventilator, you know. So I can't, I'm so happy, Jennifer, that you have your advance directives in place. I think everybody should have them. As you said, you know, it is your voice when your voice cannot be expressed for whatever reason, whether you have Alzheimer's disease, or, you know, let's say that you're commuting home from work and, you know, you're in a terrible car crash and now you're in a coma. Your advance directives speak to you. So yeah, I can't. I agree with you. I can't say enough to agree with you.
And hopefully you don't need them for a long time. But again, it's just it's your voice, it's your self-determination, and that way we don't leave people guessing.
Exactly.
So,
and I was just going to reiterate, do them when you're well, do them when you're in the early onset of your disease process, when you're not having to make decisions when you're in a health crisis.
Absolutely, absolutely. So I'd like to get back to hospice. So I wanted to just talk, you know, for just a couple moments before about best practices, what we really want to encourage folks to do. But for those, could you sort of give us the really basic definition about hospice? Pretend you're talking to someone who just, maybe they've heard of hospice, or they just associate hospice with, you're about to pass away, or maybe they have a negative connotation about hospice. How do you describe hospice?
So when I'm describing hospice, I like to start with what it isn't. And then we go to what it actually is and what it can do. It's not a place. People think hospice is a place that patients go to die. And it isn't. It's not a physical place. It's an approach to care that promotes quality of life through comfort care and symptom management. You know, if the patient, whatever their disease process is, we would manage their symptoms as a hospice team and promote their independence and quality of life for as long as we can, while supporting that natural death process. So it's not a place where people go to die. It is also not meant to be a deathbed service. The best experience with hospice is over time. So hospice, in terms of when it is appropriate to be referred, is within 6 months or less in terms of a life-limiting prognosis. The more time that the hospice team has to work with the patient and the family, the better the experience, the better that the patient and the family are prepared for death and bereavement. They can make closure, if it's possible to make closure, or they can complete some last items they may have on a list of a bucket list or whatever it may be, if it's reasonable to do that. Hospice supports all of that. We're all about living in quality of life. We're not grim reapers in hoods and with scythes. We're not coming to, overdose you on opioids, because that's another myth. I think that's out there. Right. That's not what hospice is about either. So it's an approach to caring for patients who are in that 6 months or less prognosis window to support comfortable care, quality of life, and guiding them into death with dignity.
So Jennifer, we just had one of the participants comment, Bev, says hospice was priceless for 1.5 years with me and my mom. And Bev, I'm
so glad to hear that.
I really appreciate you sharing that. But Jennifer, what can you clarify that for those who might be listening and saying, well, wait a minute, I thought Jennifer said 6 months.
Yes, so let's talk about that. The patient, again, it's a 6 month or less prognosis as the physician feels the disease is progressing. So the way that hospice works is, let's take the Medicare hospice benefit because they're the #1 payer for hospice care in the United States. The way that the benefit is set up is that there's a first 90-day benefit period, then a second 90-day benefit period, and then unlimited 60-day benefit periods as long as the patient is certified as terminally ill by the hospice physician. So depending on the patient's disease, and Alzheimer's is a perfect example where decline can be very slow, but they are declining and they are dying, but it just happens to be in millimeters versus in yards, essentially. So a hospice will take care of patients for very short amounts of time, depending on their disease and when they're referred, and they may take care of patients for longer periods of time. It sounds like this person had a really good experience over their 1.5 years. The hospice would not have kept that patient on their care if they didn't meet that 6 months or less prognosis.
So, so Jennifer, actually, first of all, I just want to say I really, really loved the way you said that the person, the way that you put it, the way that the language you used is said the person is slipping away by millimeters rather than yards. Did you come up with that, or is that?
Well, that's sort of been my analogy for many years that I've been in this niche of healthcare, because clinically that's what it feels like to me as a nurse. I've seen very steep decline with patients, and I've seen very slow decline with patients, and it seems to me that this particular disease process with Alzheimer's is something that is a very protracted decline, millimeters versus yards.
And I really think that that's beneficial for caregivers to hear that, because it really captures what's happening. Bev also just wanted to mention, who talked about her good experience with hospice, that her mom did have Alzheimer's and had a stroke, and they test mom every 3 months. And so, yeah, so like what Jennifer was saying, she still met that criteria, so they continue to offer services. So just because the doctor says it's, you're eligible for hospice now, doesn't mean you're definitely going to die in 6 months.
Right, and actually what we're seeing, Jennifer, is with some diagnoses where there is millimeters versus yards decline, we are seeing a trend of hospices discharging those patients from hospice care. And I'll give you, a scenario that is actually pretty common. A patient will come on service and they haven't had very good, consistent care. Perhaps they have caregivers attending them, where they have intermittent caregivers attending them, and their care isn't very consistent. And they meet, they come to hospice, they meet that criteria, and then we have this bevy of services that come out to see the patient and the family. We've got nurses, we've got hospice aides, we've got social workers, we've got spiritual care counselors if that's needed, we've got volunteers, we've got therapies if that's needed. All of these folks are coming out, they're attending and doing all the good work that they do, and the patient starts to look better, essentially, from a clinical standpoint, because they have all of that consistent TLC care to support them, and they have the services to support them. But with the Medicare hospice benefit, the physician has to deem them as being 6 months or less, and sometimes patients make such an astounding improvement that we call them hospice graduates, and they graduate essentially from hospice, and they come off of hospice care. They eventually will return at some point in the future, but we were able to give them that boost of palliative supportive care that helped them, and that's what they really should have been getting all along. And, you know, I'm of the mind where I would love to see insurances support palliative care, which is a precursor to hospice care, where that same comfort care approach is provided, and not necessarily going for all-out curative care, but that patient isn't in that 6-month or less window. So they just would transition from that palliative care setting right into hospice. And I think that essentially would be the best scenario for patients with Alzheimer's disease and also with other end-stage chronic diseases as well.
So what I'm doing right now, Jennifer, is I am sending out to all of now. So there's a link to NHPCO's palliative care brochure on our slideshow. So I actually just encourage everybody to look at that. And if you would like more information about palliative care versus hospice, it goes into great detail about that. So when you're talking about possibly graduating, so when do you feel like, are there specific, and I don't want to put you on the spot because I know it does vary for different folks, but is there, what to you, what are the signs that somebody with dementia, that a doc is going to say they're ready for hospice?
Well, and that's a key thing here, is that, you know, we have to make sure that patients with Alzheimer's are not referred too soon.
Yes.
Because what can happen is that they'll get into the position where they could possibly be discharged from hospice because they aren't declining, essentially. So I don't know if caregivers or anyone out there listening is familiar with the FAST scale, F-A-S-T. It's a scale that's specifically designed to measure functionability as it relates to Alzheimer's and other dementias. And essentially, when a patient gets, and maybe you can send out a link, Jennifer, to the FAST scale.
Yep.
So when a patient gets to 7C on the FAST scale, that's probably a good time to start thinking about referral to hospice care.
Did you say 7?
And 7C.
Okay.
So, yeah, you know, if the patient presents with just that particular disease process, 7C or higher is a good time where we're looking to take that patient on service. But many times, as you mentioned, there are other health issues that a patient may have. So they may have Alzheimer's, but they also might have a cardiac condition or a pulmonary condition, or they might be diabetic, or you know, they may have kidney or liver issues. So all of those other healthcare issues contribute to that prognosis of 6 months or less, even though the Alzheimer's would be that primary terminal diagnosis that would bring them to hospice.
So, okay. So is it okay for a family member to ask the doctor about hospice if they're curious? I think sometimes, like we've talked about, a lot of docs are really trying to help and treat, and sometimes what I've seen is some docs suggest on the later side. Is it okay for family members to ask the doctor about it?
Yeah, absolutely. I think they should be asking them about both palliative care and hospice care. So hospice actually, a hospice care provider can send a hospice physician out to do an eligibility evaluation of a patient. They'll come right out to the house and they'll evaluate a patient to see if they're in that 6 month or less window. And if they're not, then this patient may be a really good candidate for palliative care.
Right, which is great. And that's, we just want to make sure that the persons with dementia and their families have every service that they're eligible for and that they know about it.
Absolutely.
I think sometimes that family members, because of this trend where we sometimes do see people maybe go in and they have a week left to live, I think, do you think that in some ways, if the doctor really feels that the person meets the criteria for the 6 months, to send them, even if they are going to so-called graduate?
I think so, because, what we do see is that patients are referred and they absolutely do make or meet criteria when they're first admitted. It's just that when they receive really consistent supportive services, they may have the possibility of what we call as a clinical plateau in their status, meaning that they stabilize essentially. And they're not declining very actively, but they're not really getting better either. But they may be improved as compared to when they were first admitted to hospice.
Sure.
Their appetites may improve. They may have better functionality because of those supported services. So I'm sure you've at some point talked to your listeners about home-based community services, and there are home-based community services out there. Many times the Department of Aging can serve as the hub for the coordination of these services or referral to services if the patient really isn't meeting hospice yet, and they can receive palliative care in their home.
Absolutely.
But they maybe need additional hourly caregiver services. There could be waiver programs that might be available in order to supply that. So there are a lot of options depending on the community that are community-based services that might be helpful.
Right. Oh, absolutely. So this is very different from home care. This is different from
absolutely.
It's very different. It really is for somebody who is nearing end of life. But I think that it just talk to the doctor and just ask those questions, I think is really just, hey, and he or she might say, hey, they're not really there yet. So, but it's okay to ask those questions. So now what I have up on the screen is a link. So how you can find a care provider. So Jennifer, I want to just share with you that in all my experience, I can't tell you how many times I've worked with families who the hospital, they're at the hospital and the hospital says, okay, the doctor told you that your loved one needs hospice, and now here's the hospice you should call. And
yeah,
and that's not necessarily bad. It doesn't mean there's anything wrong with that organization, but people do have choices.
Yes, they do have choices.
We have your Find the Provider link up. So tell us about how to select.
So yes, that's the first thing to know is that you do have a choice. I believe that most hospitals, discharge planners, people of those job types will provide a list. And, not everybody is on the list for various reasons. In terms of regulations, it's not required for hospitals to provide a choice of hospice providers, if you can believe that, Jennifer. That we're working on getting that law updated through my organization. But yes, you should say, I want to be able to see who's out there. I believe that you just don't take somebody's recommendation unless, maybe you've had experience with them before, or perhaps you've had a friend who's had a good experience with that particular hospice provider. Just like you shop for anything else, you should be shopping for a hospice provider. So we do have Find a Provider in our on our webpage, where you put in your zip code, and it will give you a list of providers in your area. I consider that step one. The next tool that we do have available is a worksheet where we give you sample interview questions. Essentially, you're going to interview that hospice provider, and you can use our sheet as a guide and even add additional questions as you want to actually talk to this hospice provider to see if they're going to be the right fit for you and your family. For example, not all hospice providers believe that antibiotics, let's say that the patient contracted a urinary tract infection, right? Not all hospice providers believe that antibiotics are palliative or comfort care for treatment of that UTI. They see that as aggressive service. So those are, if I were shopping for a hospice provider, I would say, would you give my mom antibiotics if she got a urinary tract infection? That would be a question on my list. And if they said no, depending on, what you want out of your hospice provider, they may not be the right one for you. I would definitely ask that hospice provider, what's your philosophy of hospice care? If they say, we only pay for, or we only cover things that are related to X, Y, and Z, that would be something I want to ask them. Is there something that I'm going to be responsible for in terms of coverage? Now, a good question with, we haven't really touched on, Jennifer, is with patients who are coming to hospice, their disease process for Alzheimer's is advanced. And, one of the questions I would probably be asking is, with my mom who has advanced Alzheimer's disease, would you provide, let's say she's taking Amenda or Aricept, would you still cover that?
Okay.
That's a good question to ask, because
yes, it is.
When we're looking at it, let me go to the other side of the fence as a hospice clinician. When we're looking at a patient and evaluating where they are in their Alzheimer's journey, at some point, Aricept and Amenda are no longer doing what they intended to, what they're intended to do. They're no longer helpful. And that's just another pill that you're asking your mom to swallow when it's really not helpful. So I would have those conversations with a hospice and ask those tough questions.
So,
will you evaluate my mom for, reducing her medication burden, essentially? Would you pay for Aricept? Would you pay for Amenda?
So what do you think about asking questions about how they would manage pain and restlessness?
Absolutely, I would ask those things. How do you manage symptoms? How do you manage pain? How do you manage shortness of breath? How do you manage anxiety? How do you manage irritability? Because, some of these things are associated with the disease process. So,
what do you think are good answers?
Well, I think, first of all, I would be apt to like an answer where we would evaluate your mom to see what would be the best approach. Because I would never tell a patient and a family, we would give your mom Ativan, say, for anxiety. I would say there are medications available, and there are non-medication interventions that we can do as well. But we have to, look at your mom. We look at patients case by case to see what will be the best combination or the best approach for a management of their symptoms.
If you feel like the person so if you feel like your loved one is visibly in pain, or visibly restless or anxious, or visibly experiencing symptoms that seem painful, is it okay to keep asking for more help, or what are your thoughts on that?
You absolutely should be asking. You're your mom's or your dad's or your aunt's or your grandmother's advocate. They can no longer be their advocate for themselves. So they're counting on their loved ones or their representative to be an advocate for them. It's very difficult to see someone that you love in pain or restless or anxious. So we need to advocate for interventions to take care of that issue.
So it is, I mean, is there, I know that we're talking about making the person feel better and making sure that they get that comfort. I mean, is it reasonable that there might be some times where they would have discomfort?
I think that if pain management is done right or symptom management overall is done right, then there shouldn't be an instance of that.
Okay.
The only thing I can think of is when a patient is actively dying, you may have heard the term of death rattle used. And actually, it can be extremely upsetting and disturbing for those loved ones that are attending the patient, but there is no discomfort for the patient at all.
It's just part of the dying process.
It is part of the dying process, and you know, we know from research studies that physiologically, you know, the patient isn't in discomfort, they're not in pain, they're not drowning in their own fluids. It's just that you have some mucus over the voice box, and it rattles. So it makes that terrible sound, but they're not, you know, they're not in discomfort. It's more of a discomfort for the loved one. Outside of that, you know, I think if there's active anxiety, if there's active irritability, if there's active restlessness, that needs to be addressed by the hospice provider.
Absolutely. And I really appreciate you clarifying that, because, you know, if you have, as the loved one, ask the question and they're explaining, like Jennifer just did, about what they call the death rattle, which is not the greatest term, but it is a real fact of death and dying, and that it is for when someone's imminently, you know, dying. And if you don't feel like it's a reasonable conversation, it's okay to ask somebody, you know, just keep asking the questions until you feel satisfied that, okay, this makes sense or this doesn't make sense to me. And I think because death is so new to so many people.
It is. I feel like, because I started out the conversation with that it's almost become an outlier in our healthcare continuum, where, you know, when you look at the early 1900s, people were born at home. You know, they may have lived in a multi-generational home, and the elder of the people, or even if someone got ill, they died at home, attended by their family. And it was part of the life cycle, and nothing has changed in that respect. You know, mortality has extended, but we still die. And with hospice, and even with palliative care before hospice, that gives us the opportunity to die where we want to, and to die with dignity.
Absolutely. So we are going to take a couple of minutes just to acknowledge our sponsors one more time, and say hello again to Hilarity for Charity and Oasis Senior Advisors. Gosh, Jennifer is giving us so much good information, and we are actually a little behind schedule, but we're going to invite our sponsors to come. Hello. So hilarityforcharity.org, oasissenior-advisors.com. Tim Ivankovich, CEO of Oasis Senior Advisors. Tim, thank you once again for sponsoring the virtual book club for dementia caregivers.
Jennifer, always a pleasure, and love our relationship with not just you, but especially Hilarity for Charity and all that we can do for our seniors. And great to have Jennifer also on today. A lot of great information for sure.
Anything new going on with the world of Oasis Senior Advisors besides your big PBS debut?
Always fun stuff going on around here, but to kind of focus it on what you guys are talking about, especially in the early stages, one of the things that our advisors do extremely well is have those conversations. You know, so often we're dealing with families that are, in essence, kind of in denial that it's either time for assisted living or in some cases time for hospice. So again, I think this topic is extremely pertinent in helping people understand when is that right time to decide. And again, what our advisors, I think, do very, very well is help those families have that conversation and kind of teach and train and how to best approach the senior, how to best approach other family members to make those decisions, whether it's, you know, directives or whatever it may be, but how to have those conversations.
Definitely. So Tim's organization, Oasis Senior Advisors, there's over 80 franchises, oasissenior-advisors.com. And if you missed it, last week was Family Pictures. Family Pictures USA, correct. Family Pictures USA on PBS. You can catch it on the app or the website still. Mm-hmm. Correct. Yeah. So Tim's organization, Oasis Senior Advisors, sponsored that. Not too late to check it out, even if you're viewing this later. But check out Oasis Senior Advisors if you think at some point you may need some help with figuring out options for your loved one. And just like Tim's been telling us, the whole book club, they're not just there to connect you with senior living. They can help sort of talk about some of these issues like we're talking about today, hospice, end of life, sort of help broker some of these difficult conversations. So once again, thank you so much, Tim.
Pleasure, Jen.
And now I'd like to offer up thanks to RJ Mercedes, the Director of Programming and Development with Hilarity for Charity. Hi, RJ.
Hi there.
Welcome back, and thank you again for sponsoring this program. Anything that you would like to share today? I know we talked about, Jennifer was talking about how we don't have a cure, but your answer is?
Care. Yep, exactly. Well, just want to appreciate everyone for joining today or watching after. I know it's not an easy conversation, but it's a really important one. So really want to thank Jennifer for all of her guidance and taking us through this, and to Jen and Tim as well. Yep. So as we know, Hilarity for Charity is here to support families today. And that's through our caregiving, our care grants, our support groups, our storytelling wall on our website, in different ways that we can get people really talking, so that it's not felt like it's this stigmatized disease that they can't go to for help.
And is that hashtag many stories of Alzheimer's?
Many faces of Alzheimer's.
Many faces of Alzheimer's. And actually earlier today, we received a question that came in, and it was specifically for Hilarity for Charity. Mm-hmm. So I just want to pose it to RJ. The question was about, we had a participant who's been on book club ask about the fact that his loved one, he's the primary caregiver, and he takes care of the finances for his parent. His parent actually has a dementia diagnosis, but she's living a very, very, very long time. She saved really well for retirement, but they've spent most of the money. And he was wondering, he actually used the word, is it ethical? Is it moral? He even used the word legal for him to ask, apply for a Hilarity for Charity grant to help with his mom, because he was saying that he actually has a good amount of savings for his own retirement. So he was curious, like, what Hilarity for Charity would think of a situation like that. Would they welcome an application from him, or what their thoughts would be?
Well, it's certainly a devastating situation to be in, right? And going back to Jennifer's comment before around, it's a millimeter, not a yard, a lot of times, and that this disease can unfortunately go on for 15, 20 years. So it is hard, especially if you're just kind of waiting to try to properly plan for your loved one's end of life and just your own savings as well. So I just want to say that everyone should be comfortable asking for help. It's never wrong or unethical, and that we really are here to support you today. And we know that Alzheimer's doesn't just affect the person, but really the family. So this is really where we want to be here to help everybody. We do focus on respite relief, so not hospice. So we definitely want to make that point. And then I'll just say also that our grants are pretty competitive, just based on our capacity to give each month. So we just asked everyone to be really upfront and honest about their situation. So as we kind of say that the specifications in order to apply is that your loved one lives at home, that they have a professional diagnosis of Alzheimer's and other dementia, and that you have significant financial or emotional hardships. So that's it. We really want to know more about your situation, and the more kind of open and honest you can be with us, the more that our review committees can take that into consideration.
Thank you. And it's a really good question, because we've talked in Cruising Through Caregiving Book Club a lot about how you got to set boundaries with your own money sometimes. And if you spend all your money on your parents, what they need, maybe your kids are going to have to pay for everything for you. And that's a spin-off effect for many generations. So thank you, RJ. So I would say to that person who emailed in today, send that application in and see what happens, and just try to give them as much honest information as you can. And you know, again, it is highly competitive, but do send that application in.
Yes, please do.
Thank you, RJ. And thanks again, hilarityforcharity.org. We really appreciate our partnership with them. So we just have a couple more minutes. So I want to get back to Jennifer. And Jennifer, I think RJ repeated your words about millimeter rather than yards. I think you're going to have everybody on this program using that phrase.
Oh, well, good.
It's so perfect. It's so perfect. I'm
glad to pass it along.
Everyone, I knew it would resonate with everybody. As soon as I heard it, I thought, wow, that's really where it is. But I just want to make a quick comment that grief and dementia is different. Dementia can be really long, and like Jennifer said, millimeters rather than yards, and you might be grieving a really long time at different stages. And there could be a point that when you get to hospice, in some ways, it might feel like a relief. And so please don't let yourself feel guilty about that. All caregivers are doing the very best that they can. Hospice and bringing in hospice, and sometimes it is normal to feel that relief. So I just wanted to share that. So as far as course correcting, just what we say about when we need to make a change in what we're doing for dementia care, I just want to say, please consider, if your loved one is in the early stage, please consider talking to them, getting their ideas about what they do and don't want, and encouraging them when they have moments of clarity, see an elder law attorney if you need to, get your paperwork in order. If you are a family caregiver, you're the captain of the caregiving ship, not just for yourself, but if something were to happen to you, please put your paperwork in order as well. And finally, Jennifer, actually, I'm going to leave you with one last thing. And for those of us who are joining us on the YouTube page after the fact, we're taping this in August of 2019. But Jennifer, recently there was a big story in the news. It's still a big story in the news about Valerie Harper and her husband. Valerie Harper's had cancer for many years, and I guess her physicians had recommended hospice. And her husband has been really public that he's not going to give up on her, and he would never do that. And is there anything what do you think about a statement like that? You hear statements like that quite frequently. How do you help people get out of that mindset that it's giving up?
Yeah, and I think that, that's one of our biggest battles, being hospice providers and clinicians, is that there is that myth or that mindset that hospice is just, right at the right end of it, the last few days or even a week before. And I think I would say I would like to talk with him to talk about how hospice could be helping him right now. Yes. In terms of both him and Valerie, in terms of promoting quality of life for her, managing her symptoms. One thing that we do is, in addition to helping people make closure, is we do life review with patients, where they talk about their life, and they either, they video it or they record it, and somehow it is therapeutic to talk about all of your life milestones, things that went well, things you had regrets about. All of that is, really working towards that acceptance and being able to let go peacefully whenever nature takes its course. There are many, many things that I think the average person out there doesn't realize that we can help with. We're not just there to bring the medicines to the house in terms of, opioids or controlled medicines. That's not what we do. It's part of what we do, but we're a whole interdisciplinary team that comes to treat the patient and the family in a holistic manner.
And this could be a blessing to the Harper family.
It could, absolutely. It may take a lot of burden off of them.
And it wouldn't be giving up. Now, just to clarify, I think we all know, everybody that's on today knows that probably doing a life review with someone with late stage dementia would be difficult because there's a lack of verbal ability and awareness. So that probably wouldn't be we probably wouldn't be as likely to be able to do that. But the other thing I did want to ask about, Jennifer, just for our last minute or so, is I know that you mentioned that hospice is not a place, but I know that there are probably people thinking, well, wait a minute, I know that there are hospice communities or hospice houses. Most hospice, of course, does take place at home where the loved one lives, but it can take place in assisted living if the loved one lives there, or nursing home. But tell us about, real briefly, just when somebody does live in, when they do go somewhere outside the home for hospice, under what circumstances would that be?
Sure. So I'm glad you said most of it's hospice care is provided in the home. It's provided wherever that patient calls home. So we see patients, as you said, in assisted living facilities and nursing facilities. The patient may go for a short time to a hospice inpatient facility if they're having an acute crisis of symptoms. They're having pain that we can't get under control in the home setting, or shortness of breath, or whatever the symptom may be, where they need that 24/7 supervision and attention and care for us to monitor them and try interventions to get those symptoms under control. But as soon as those symptoms are managed, then they come back out and go home to wherever it is they want to be. There are also hospice houses or hospice residences out in some states and some communities, and it may be that a patient may go there for a period of time if they decide, or with the decision of their caregiver or the caregiver making the decision, that they need more intensive 24/7 care, but they don't want to go to a nursing facility for that.
Right. Okay.
But the stay in a hospice residence is not long-term. It's for a short-term period. Usually about a month is a time frame, and the hospice house may serve as a transition for the caregiver to make decisions about, is it time for a nursing facility situation, for instance.
Right. Okay. Thank you so much for clarifying that. I really appreciate that. Well,
my pleasure.
I got to tell you, this has been such a wonderful conversation. You're so knowledgeable. We were so fortunate to get you on this program today. Thank you to Jennifer Kennedy, Senior Director, Dr. Jennifer Kennedy, Senior Director of Regulatory and Quality for the National Hospice and Palliative Care Organization. And thank you again to our sponsors, Hilarity for Charity, hilarityforcharity.org, Oasis Senior Advisors, oasissenior-advisors.com. Next week, we are going to be talking not just about life after caregiving, but also how to keep yourself as healthy as possible to possibly reduce the risk for your dementia. So thank you all for joining us today. We look forward to seeing you for our last session. For those of you who are joining us live, if you have any questions for next week, send them to Jen at generationshealth.com. Thanks, everybody. Have a great evening.